Hello and welcome to the June 2023 edition of the IMV Imaging Journal Club. This month I've chosen an equine radiographic study in celebration of our recent acquisition of Veterinary Solutions, which is a Belgium-based company specializing in digital radiographic systems and PACS image storage solutions. The paper is entitled "The Effect of Manually Facilitated Flexion of the Thoracic Spine on the Interspinous Space Among Horses with Impinging Dorsal Spinous Processes of the Thoracic Vertebrae." It's a study that was published towards the latter part of 2022 in the Veterinary Journal. Impinging spinous processes, which can also be called impinging dorsal spinous processes, although adding the dorsal isn't necessary, is more colloquially and commonly known as kissing spine. It's the most common spinal pathology reported in horses, and it can be considered primarily a radiological diagnosis because it quite literally describes the observation of two spinous processes which appear to physically touch or sometimes overlap. I've pulled two examples from clinical cases here. So on the left, there's one horse with two close spinous processes. Although what we'll notice, although they appear to touch, there are no other radiological observations here. Compare that to the image on the right, where there are several either very close, physically touching, or what appear to be overlapping spinous processes. And in addition, there's increased opacity, which is more obvious in the caudal aspect of the involved spinous processes, as well as several areas of radiolucencies and also some bony irregularity around the margins. The condition is associated potentially with a number of clinical problems, including those which can be thought of as relating to lameness or poor performance, such as poor hindlimb impulsion, difficulty with some certain moves like flying changes and lateral work, and similarly some sort of behavioural spectrum problems, such as not working on the bit, stopping, refusing to go or rearing, and cold-backed behaviour, so a reluctance of varying degrees to application of the saddle or a rider. There are also several physical findings, and that can include tension or pain on palpation of the epaxial muscles, which then themselves may be poorly developed, and also reduced back flexibility. But it's important to note that none of these observations is at all pathognomonic for primary thoracolumbar pain, and whilst a horse with painful impinging spinous processes may well display some or several of these signs, horses with other sources of pain contributing to lameness or poor performance, such as sacroiliac pain or limb pain, can display this full range of clinical signs and physical examination findings. Horses with clinically relevant thoracolumbar spinal pathology, so not necessarily just impinging spinous processes, may have some more specific localized physical signs, such as eliciting a painful reaction upon palpation of the summits of the spinous processes, localized swelling or thickening of the supraspinous ligament, which is that ligament that runs directly dorsal to the spinous processes. And again, it's important to sort of differentiate that any horses with pectoral supraspinous ligament pathology, supraspinous desmitis, from any horses which may have impinging spinous processes, because these two structures are very closely anatomically related. And thirdly, horses which have a very severe restriction of flexibility and may display agitation either when they're asked to dorso-ventrally flex or extend the thoracolumbar spine, or as in this example here where the horse is asked to turn in a small circle, so trying to elicit a lateral bend, and he shows a lot of restriction and agitation. these are kind of things that we might see more specifically perhaps in horses with actual primary painful thoracolumbar pathology. So potentially that could include impinging spinous processes. It can affect typically between the 10th thoracic and 2nd lumbar vertebrae, although most frequently impinging spinous processes are observed between the 13th and 18th thoracic vertebrae. And that's because these are the spinous processes centered around the anticlinal vertebra. So that's considered to be the 15th thoracic vertebrae, and that is the junction where the caudally oriented spinous processes of the cranial thoracic spine become vertical at the anticlinal vertebrae, and caudal to that, running into the lumbar spine, the spinous processes are oriented in a cranial direction. So this is logically the predilection site for impinging spinous processes, because this is where the spinous processes in all horses quite naturally converge. On the right is an excerpt from a study developed, written up by Marika Zimmerman back in 2011. This is a 7-point grading scale which is developed to grade the severity of radiological changes associated with impinging spinous processes. And this takes into consideration not only the presence of impinging or overlapping spinous processes, but also other radiological findings such as increased radiopacity, the presence of radiolucent zones, modeling or new bone formation, and whether there has been a change in the shape or even fusion between adjacent spinous processes. Taking a brief jump into that Zimmerman study, because I think it gives us quite a good overview of impinging spinous processes and puts them into a little bit more context. So out of the 582 horses in this study which had either perceived back pain or had poor performance, less than half of the horses which had impinging spinous processes in this population actually had confirmed thoracolumbar pain. So 54% of horses with impinging spinous processes did not have any pain associated with those lesions. Looking towards in the middle of the data sets here, both the number of impinging spinous processes and also the severity of impingement as graded on the 7-point scale were positively and significantly correlated with an increased likelihood of clinical relevance. But as we can see, there is no black and white cutoff for what equates as significance. So whilst the greater the number affected and the greater severity observed, there is still potential that some horses which have, for example, up to even, as we can see here, 10 impinging spinous processes, maybe even with a grade of 5 or 6, could still have that, but without any associated pain or other dysfunction. So this just really highlights that there is a huge potential for overdiagnosis of impinging spinous processes when radiography is used. It's previously been reported that posture can influence the interspinous distance. So back in 1980, horses with orthotic posture tended to have, well, they had more extended thoracolumbar spines and therefore closer interspinous or smaller interspinous distances. More recently, in 2012, a group investigated the spinous process separation according to the head and neck position, and they found that with a lower head and neck position, there was greater spinous process separation. Conversely, when the head and neck were in a high position, the spinous processes were smaller. So, of course, I think we know that the thoracolumbar spine, the back, is a dynamic structure. And so that does lead us and these authors to question, is it possible that impingement is dynamic? I think the study by Berner et al. Proves that yes, impingement potentially is dynamic, but this group wanted to investigate this a little bit further. So they developed the aim, which was to ascertain if the interspinous spaces would increase with facilitated spinal flexion in a group of horses with impinging spinous processes. They did develop some hypotheses, and I've just teased them out from their introduction. And these were that manual facilitation of thoracic flexion in horses with impinging spinous processes will firstly increase the interspinous space distance, secondly, lower the grade of impingement, and finally, change the diagnostic and therapeutic approach. Looking at their methods, this was a prospective study performed at the University of Helsinki Veterinary Teaching Hospital. They had some inclusion criteria, which was all horses were above 3 years old, and that they had to have had mature vertebral bony development, although they didn't detail exactly how they determined that in this group of horses. All the horses are ones which had presented for assessment of back pain or which had a previous diagnosis of impinging spinous processes. It wasn't clear whether the previous diagnosis was whether that diagnosis was reached at a previous visit to the University of Helsinki Veterinary Teaching Hospital, or perhaps it was a diagnosis that performed by a referring veterinarian. It wasn't clarified. There were some exclusion criteria, and that is that horses with previously diagnosed impinging spinous processes were not included if they'd had previous surgical treatment of any type, and also some smaller breeds such as Shetland ponies and miniature horses were not included. For radiography, the patients were positioned so that they were standing squarely and the head was held so that the mouth was level with the shoulder. They did trial putting the head on a table, but they didn't feel it was practical, so they continued through the study just to handhold the heads. All horses were chemically sedated to, I believe, varying degrees depending upon the temperament of the horse. Some of them did need top-up sedation in order to keep them at an adequate level of sedation for the procedure to be carried out safely and effectively. And horses were either sedated with a combination of tetomidine or butorphanol, tetomidine and butorphanol, or with xylazine alone. So for the actual radiographic technique, they acquired 2 sets of lateral radiographs, including the spinous processes between the 5th and 18th thoracic vertebrae. Firstly, the horses were positioned in what they termed spontaneous posture, so positioned as previously discussed, and following that, one observer performed a manual facilitation of thoracic flexion. So I've included an image on the right of what that exercise looks like. It's sometimes referred to as a thoracic lift. It's where pressure is applied to the ventral aspect of the sternal region of the horse to elicit spinal flexion, which is predominant in the thoracic spine. And the radiographs were acquired at what was deemed by that observer to be the greatest postural change in that individual horse. The measurements were acquired at a later point by one blinded observer. The experience level wasn't described, but this person measured the distance in millimeters between adjacent spinous processes at what was considered to be the narrowest point, so somewhere between, or at all interspinous spaces between the 5th and 18th thoracic vertebrae. This image on the right is one that it's not from the study, but it's one I pulled up myself and added arrows to it. What I wanted to show is that from the figures included in the study, it appeared that not all measurements were acquired with the measurement in a horizontal plane, such as the arrow on the very far left of the image, but some were acquired at oblique angles. So because there was no repeatability study performed, there's a little bit of a question as to how repeatable these measures were if it wasn't, for example, a rigid requirement for all measures to be acquired in a horizontal plane. The spinous processes were identified according to identification of the 5th thoracic vertebrae, which was deemed to be the vertebrae with the highest spinous process. In other studies and clinically, quite often and more frequently, I've come across vertebral identification performed following identification of the 18th thoracic vertebrae, primarily if vertebral body lateral radiographs are required, specifically so that one can see the articulation of the 18th rib with the 18th vertebrae, which gives us a quite accurate, gives a lot of confidence in identifying the spinous processes accurately, and also identification of the 15th or anticlinal thoracic vertebrae. The mean of 3 repeated measurements was used for statistical analysis, and statistical analysis was reported as means thereafter. They applied a modified grading scale. This was a 0 to 4 based scale, and that was based upon the distance measurements from the 7-point grading scale, but all other radiological parameters were not considered, which is why the 7-point grading scale was toned down to a 0 to 4 grading scale. They did also perform some conformational measurements, so the length of the thoracic spine, the height of the horse at the withers, body weight in kilograms, which was acquired from the use of calibrated scales, and the thoracic circumference. Statistical analysis was primarily descriptive, but they did also perform Hodges-Lehmann estimates of medians. So this was calculated for each intervertebral space, and it was a reporting of the median difference in millimeters between these two radiographic sets, so between spontaneous and a flexed posture within the study population. Moving on to the results, 7 horses met the inclusion criteria, which is quite a small population group. The average age was 9 years, with a range or interquartile range from 7 to 12, and there was a variety of breeds, predominantly warm blood, which is probably quite reflective of their typical study of their hospital population. The conformational measures were reported as an average and also a range, but I just note that there was no further analysis of this data, and so to some degree it is slightly unclear to what contribution this data had to the study. I think it's interesting to consider these measurements in relation to a study that is measuring the interspinous space distance in millimeters, but I think it would have been interesting to compare this data with that for the variables or the measured variables in this study. But I understand that perhaps this wouldn't have been looked at potentially because of this small population study. This is one of the figures from the study, and this shows a box and whisker plot for data which is collected for all horses. So each colour pair here represents one interspinous space, with the data points on the left of each pair pertaining to spontaneous posture measurements, and the data points on the right of each pair pertaining to the results from the flexed posture. So this is box and whisker plots report the median, the interquartile range, and the true range for the data. So things to note of interest here. It does quite nicely demonstrate the overall trend for greater interspinous distances cranially, that's towards the left of this figure, which reduce over the mid and towards the caudal thoracic region. There's also quite relatively wide ranges of data, with a lot of overlap between the first and second measures for each interspinous location. And what this tells me is that if, for example, this was a larger study population and more robust statistical methods could have been performed, then ranges with such a degree of overlap is very unlikely to show any significant difference in measures between between the two postures in this study. At this stage, they did also, at the bottom of this figure, report the Hodges-Lemon values of the differences between the two medians. And those Hodges-Lemon values correlate quite nicely to what we can very visually see on the box and whisker plots between the medians of the spontaneous and flexed position measurements. Vast majority, so almost 98% of interspinous spaces widened following facilitated thoracic flexion in these horses. The largest difference in millimeters was observed between the 7th and 13th thoracic vertebrae. I think it would have been really nice to have seen this as a proportion and not just as a distance measurement in millimeters. Which ones reduced or sorry, increased in distance more as a ratio or compared to the original values. Whereas the smallest distance was reported between the 17th and 18th thoracic vertebrae, so little movement there. All horses, of course, had impinging spinous processes. That was part of the inclusion criteria. And the number of affected interspinous spaces was between 2 to 4 per horse. And the grading, according to the modified 0 to 4 grading scale used in this study alone, varied between 1 and 4 for all of these identified lesions. Impinging spinous processes were most frequently identified between the 13th and 16th thoracic vertebrae, and that is nicely correlates to previous reports and what we would expect in a clinical population of horses with these lesions. 18 out of 20 of the impinging spinous process regions identified reduced to a lower grade following flexion, so in that second radiographic set. Of those impinging spinous process locations, over half of them were reduced to a grade 0. So in this grading scale, that would be considered normal, and those horses would then not have been diagnosed with impinging spinous processes. I think it would have been interesting if the grade, according to impinging spinous process location, would have been presented. And I think it would have been nice to answer the question or look into the fact that, were the spaces increasing most or least related to the presence of impingement or the grading or not. And that would have been something that I think I would have found quite interesting to know, which we can't glean from the data as it's presented. So moving on to their discussion. So I like to start by just revisiting their hypotheses to ask the question, did they prove the hypotheses that they set out to investigate? Well, looking at the first two, I think to a degree, yes. So they did show that manual facilitation of thoracic flexion in horses with impinging spinous processes did increase the interspinous space distance and did lower the grade of impingement. I think a couple of important caveats here just to consider. So there was a degree of unhomogeneity within the study population. So we know that all of these horses had static or spontaneous posture impingement, but we don't know that in these horses whether some or all of them had pain. Were these impinging spinous processes of any clinical significance to these horses? We just do not know. Secondly, we know that there was an increase in interspinous space when comparing just visually the medians, but again, the statistic analysis was not robust. It was a very small data set here, and it's likely that there would be no significant difference. So again, the importance of this change, I don't think they have proven in this study. And similarly, lowering the grade of impingement. Yes, the grade was lowered using their scale, and I think that is certainly an important observation. I think the one thing we have to be aware of is that the scale used only took into consideration the proximity of impingement and therefore whether that was dynamic or not. We don't know how that correlates to clinical findings, whether there's a definitive diagnosis of a painful impingement spinous process, and thereafter how does it correlate to prognosis, to management, to treatment, to outcome? We just do not know. In an ideal world, it would have been fantastic for them to use the clinically used 7-point grading scale, because using the 4-point grading scale alone, we just do not know how that correlates to clinical practice and clinical cases. Then looking at the third point, which I teased out of their introduction, as I said before. So they didn't necessarily state that this was their third hypothesis, but it was included in their hypothesis sentence. Was that would it change the diagnostic and therapeutic approach? These things were not investigated, so I don't think that they proved this at all. But perhaps they weren't actually setting out to investigate this, and they may not have just been that clearly worded in the introduction. So just looking or picking up on a few things of interest that they mentioned in their discussion. So they stated that facilitated thoracic flexion did increase interspinous space in this group of horses. But again, we do not know how a diagnosis was reached in these horses. It wasn't reported. The authors discussed the importance of not reaching a diagnosis based on radiographs alone, but in these horses we don't know what extra diagnostic tests, if any, were performed, and as such we don't know whether these horses even did have a definitive diagnosis themselves. As they discuss here, just in this middle section, I agree that, and I think it is known to be correct, that horses with impinging spinous processes are sometimes considered candidates for invasive surgical procedures. However, not all horses with impinging spinous processes do require surgery. They can essentially be, to a degree, incidental and not causing any pain or discomfort. In some horses, we only know about them because the back was radiographed, rather than them displaying any primary indicators or specific indicators of primary back pathology. And because the back is dynamic, they may also not be causing any functional abnormality. But I hasten to say that I don't think that is to say that they are ever necessarily normal, and I don't think they should be ignored, but they just don't always need invasive surgical procedures. I suspect and I think that they're perhaps an indicator of or a result of either poor posture or core stability. I think there's a real continuum between normal and the extreme of impinging spinous processes. I don't think there's really a cutoff in horses as to when they become, I guess what we could say, clinically relevant and painful to the degree of needing surgery to alleviate them. Potentially some early indicators and early identification. Do those horses, or would they go on to develop more severe lesions that need surgery later down the line? It's possible. Could correcting poor posture and improving core stability improve or even reverse impingement? Again, possible. So I don't think they're ever worth ignoring. I'm simply pointing out that sometimes I think a lot of horses probably have impinging spinous processes without any recognised back problems at all. The authors then go on to discuss the importance of finding out more about the interrelationship between posture and the proximity of spinous processes, and this is what they discuss towards the end. And this leads to the question, does the ability to manually encourage spinous process separation with thoracic flexion exercises, does that help to differentiate those with clinically relevant versus perhaps postural impinging spinous processes, or static versus dynamic cases, as they've referred to these different groups of horses as? It might be a little bit simplistic, because I think it's a really interesting point, but whilst we know that, for example, horses with higher grades of impinging spinous processes are more likely to have concurrent spinal pathology, for example, this in itself may limit thoracic movement. So it might not necessarily be because of the impinging spinous processes that there's any primary back prevalence. It might just be concurrent with other more important spinal pathology, which is causing perhaps the pain and the dysfunction. And also that there's so many confounding factors to this, and we just don't know how it relates to clinical practice yet. But I think, again, I do think that this is all pointing towards an area that needs more research, and we do need to find out some more so that we can apply it to clinical practice. Finally, the authors conclude at one point that measuring the potential space between spinous processes, so the space that can be achieved with flexion, may differentiate true versus poor posture related impingement. Again, the reality is that I don't think that we know the difference between these groups, and we don't know whether the measures in this study would differentiate these groups. So I think we don't actually have the essential data to back this up as yet. Despite knowing that if more robust statistical analysis was performed, that there would be no significant difference of the median interspinous distance change, they then go on to state that the results emphasized a clear clinical and functional significance of median interspinous distance change in these horses. But the results here have not been correlated with clinical or functional parameters. And although they do then absolutely go on to discuss and state something to that effect, I just think this sentence at the top could be considered a little misleading, if not read in light of their sort of further explanation. So I just think at times some of the sentences feel quite that they're written with quite a lot of confidence about what the results could mean, and then they do highlight a lot of limitations, but perhaps I feel at times don't put it into context as well or as clearly as they otherwise could have done. So discussing some of the limitations, we've already gone over some of these, and many of these are discussed within the body of the text by the authors. Again, the reduced grading scale, it would have been more clinically relevant to use the full grading scale, I feel, the one as developed by Marika Zimmerman. And it would have been more relevant to ascertain whether posture could affect a clinically relevant and clinically proven scale. We just don't quite know what the modified steroid force scale means. There were only 7 horses, it was small, as they acknowledged, and many more would be inquired in order to evaluate the data with more robust statistical methods, including assessment, ideally of both clinically normal horses as well as those with impinging spinous processes identified which may not be clinically significant or not causing pain, and also those with ones which are causing pain and are causing a primary back problem. Some interesting points with regard to the posture in sedated animals. All these horses were sedated to varying degrees, and therefore does what we believe is their spontaneous posture while sedated, does that reflect or mirror the posture they would adopt if they were non-sedated? It's possible that is not the case. Of course, as we know, a sedated horse will relax, they might sway around, and so they may stand in a slightly different posture, potentially a more lordotic posture than they would otherwise. And again, we're relying upon achieving a maximum degree or the greatest point of excursion in thoracic flexion in these horses. But if some horses did need to be sedated, perhaps quite heavily, to acquire the radiographs, it's possible that all of them, to varying degrees, may have had reduced range of flexion because you just simply can't achieve that same degree in sedated horse. Again, where the muscles are relaxed, the horse probably isn't paying attention and becomes a kind of more stoical to an observer or investigator trying to elicit a movement. Again, 3 points here that I didn't feel that they touched on in their discussion or throughout the text, but I think are worth describing. or discussing, is that it was a non-homogeneous and I think quite poorly defined population. It would have been ideal to know more about how a definitive diagnosis was reached in these horses, so we have more of an idea of what these impinging spinous processes meant for the horses and what kind of population we were dealing with. Again, there were no repeatability studies, which would have been ideal both within the same observer and also between multiple observers. So, can these measurements be acquired accurately between different people? Another point is variable magnification in radiography, which is well recognized. Depending upon the relative positions of the patient from the cassette or detector and from the generator, that will result in variable magnification. So that will affect measurements acquired as a distance, for example, in millimeters, as in this study. So the millimeter distance recorded in this study won't reflect the actual distance anatomically in these horses, and that degree of magnification can vary within and between patients. And that wasn't accounted for or discussed, which I feel should always be discussed in radiographic studies. And then finally, again, we've touched on this, but the results of this weren't correlated with either clinical signs or findings in these horses, nor with a definitive diagnosis, and nor with function. So we can't draw any conclusions between the data recorded here and any of these potential outcomes in the horses. So moving right to the end to look at their conclusion. So their conclusion was that the results of this small study demonstrated that the median distance between spinous processes of the thoracic spine increased following manual facilitation of thoracic flexion and resulted in reduced thoracic spinal lordosis. They then go on to say that the results support the need for more dynamic and functional evaluation prior to a diagnosis of impingement, particularly when radiographic grading is based on the interspinous distance and may result in invasive intervention. So I think I certainly do support what they've said here, although I do think that there are quite a few caveats. I think certainly looking at that first conclusion sentence is that yes, they did show that there was a difference, but it was again a small study population. We're not sure how with regards to wider populations of horses, how we can apply that, how we apply it for more severe cases, how we can apply it for normal cases, we don't know. It certainly does add weight to the argument against diagnosing impinging spinous processes of clinical significance based on radiographic parameters alone. And I think this is something that I think is a really important point. And I think part of this is why I chose this study, is that I know and I've seen how easy I think it appears to be to overdiagnose or over-assign clinical importance to impinging spinous processes, because we know that they're common, we know that back pain is common, and so it is all too easy and simple to put two and two together, but it's not always the case. These cases are complicated. It's not easy to tease out the relative importance of different sources of pain in poor performance and cases in horses with back pain. But I think basing on radiographic measurements alone is certainly inappropriate. That was also looked into by the Zimmerman study. But further than that, I think looking at radiographic measurements and findings, even as an entirety alone, shouldn't be done. And I do believe it should always be diagnosed in conjunction with the use of diagnostic analgesia, firstly to rule in or out the importance of, for example, hind limb pain, sacroiliac region pain, and thereafter, if there's still a question over clinical relevance in association with impinging spinous processes, infiltration of anaesthetic solution around those impinging spinous processes in order to see clinical improvement or not is important. I think, again, it also does support impinging spinous processes as a potential outcome of, for example, poor posture and core stability. It's adding weight to our knowledge base that some horses do appear to have impinging spinous processes, which might be, for example, dynamic, just a reflection of poor posture. It may not be representative of clinical painful condition. So I found this a really interesting study. It's a topic I quite enjoy reading about. So even though I don't think the results of this study is directly going to influence, I think, what we do in clinical practice with clinical cases, I think it's opening up and strengthening the argument for more research and for us to find out more about the relationship between posture, impinging spinous processes, radiographic measurements, and how that can be affected in the dynamic horse, both from, for example, the performing of these measurements, but also what happens to the spinous processes during ridden exercise when we know that the back changes shape during and after ridden exercise. So a whole host of questions here. It would be fantastic if our further studies performed in this area by the same or different group. So interesting study, and I hope you enjoyed either reading the study or just listening to this summary with us. So thank you for attending. As always, please do visit our website or various social media pages to find out more. There's always various resources, for example, pertaining to thoracic radiography in horses, if you're interested. And also, if you have any comments or questions associated or off the back of this, then please do get in contact. The email address is clinical@imv-imaging.com, and we'd love to hear from you. But for now, thank you for attending, and goodbye.